Good day. Today we're going to talk about paraphilic and fetishistic disorders. First, let's talk about pedophilic disorder. Based on the criteria for the DSM-5, one must experience 6 or more months of fantasies, urges that are sexual in nature involving prepubescent children, or they must act on these sexual fantasies or urges. In order for a teen to be diagnosed, they must be 15 and have sexual urges for someone who is 5 years younger than them. It is not necessary for these urges or desires to be thought about for 6 months. If you offend, then you could meet the criteria for pedophilic much earlier. There are 2 different types regarding pedophilic disorder. One is exclusive. This means that the person is incapable of having sexual or romantic relationships with mature adults and exclusively has interest in prepubescent children. Non-exclusive means that the person is able to develop romantic and sexual relationships with adults and both has a preference for prepubescent children. People with pedophilic disorder are sexually aroused by the thought, imagery, or presence of prepubescent children, either more than they are with adults or equal to their desire for sexually mature children. Without the act of sexual conduct with children, this could be considered pedophilic sexual orientation. These are dreams, fantasies. The key takeaway with pedophilic disorder that is different from other mental health disorders is that there is a lack of or no reported distress, guilt, or anxiety. The prevalence for this disorder specifically is unknown. However, it is estimated that in males, 3.5% of males will be or have been diagnosed with pedophilic disorder. In females, it is more uncertain due to their nurturing nature that reported sex offenses against them are usually more blurry. Of people convicted of sexual assault offenses, 30 to 70% are found to be diagnosed with pedophilic disorder. This is a lifelong disorder. However, it could fluctuate through time and treatment, and desires may increase or decrease as the person ages. When someone is diagnosed with pedophilic disorder in conjunction with antisocial personality disorder, they are at the highest risk to offend due to their lack of empathy for their behavior and their lack of remorse for their victim or anyone else. There are certain comorbid disorders as well, such as bipolar disorder, anxiety, and other paraphilic disorders that we'll talk about later. Diagnosing this disorder, you don't have to necessarily use the DSM by itself. It is important to converge data or converge assessments, usually because this diagnosis is not based off self-reporting and you have to work in conjunction with law enforcement. An example would be the PPG or VPG, which measures the volume of body parts when relaxed and excited. So someone will expose the offender or accused offender to children or prepubescent children and monitor the swelling of the penis or the swelling of the vagina walls when hooked up to this device. Another one is the RASOR, RRASOR. The higher the score, the more likely the person is to reoffend. Now let's talk about treatment and implications. ADP, also known as chemical castration, what this does is it decreases the testosterone levels in male to the point to where they lack libido, as well as cannot maintain an erection. Previously, that was used. Now we're moving more into the SSRIs, such as Zoloft. This naturally decreases libido and also decreases sexual arousal in both men and women offenders. Cognitive behavior therapy is also effective in the prison and community care center. Aversion therapy is also effective when the offender is taught or encouraged to negatively associate terms or feelings with the sight or thought of prepubescent children. Therapeutic confrontation is done in the prison system group therapy. This is when the offender talks about the crimes that he committed or the sexual urges that he has towards children in a group of people where they could discuss the importance of why this behavior is inappropriate and be confronted for their crimes or their acts. Community care is when you get the family and coworkers and all parties involved, social workers as well, to monitor and help the recovery
Now
of
on
the
to
sex
sadism
offender.
disorder.
Sexual sadism entails sexual behavior in which the mental and physical suffering of a victim is experienced as erotically pleasurable. The word sadism comes from the infamous Marquis de Sade, a French count, writer, and philosopher. To be diagnosed with sexual sadism disorder over a period of at least 6 months, recurrent and intense sexual arousal from the physical or psychological suffering of another person as manifested by fantasies, urges, or behaviors must occur. The individual also has to have acted on these sexual urges with a non consenting person, or the sexual urges or fantasies cause clinically significant distress or impairment in their life. There are two types of sexual sadism disorder. One is in a controlled environment or in full remission. In a controlled environment, the specifier is primarily applicable to individuals living in institutional or other settings where opportunities to engage in sadistic behaviors are restricted. In full remission, the individual has not acted on the urges with a non consenting person, and there has been no distress or impairment. The prevalence of sexual sadism disorder is practically unknown and is largely based on individuals in forensic settings. The prevalence varies widely from 2 to 30%, and also among individuals who have committed sexually motivated homicides, the rates of sexual sadism disorder range from 37 to 75%. At this time, there are no universally accepted causes or theories explaining the origin of sexual sadism. There have been some researchers that have attempted to explain the presence of it, such as some believe that paraphilias are related to such problems as brain injury, schizophrenia, or other mental disorders. Another theory they have is that the person is required to suppress or hide their inappropriate sexual fantasies so they get an increased urge. The treatment for this disorder is often behavior therapy, which may include the management and conditioning of arousal patterns and masturbation. Therapies also could involve cognitive restructuring, and social skills training are also often utilized. Medication may be used as well to reduce fantasies and behavior relating to paraphilias. Medications that are used are female hormones, which is MPA, and it is used to speed up the clearance of testosterone from the bloodstream. Anti-androgen medications, which block the body's testosterone uptake. and selective SSRIs. People with sexual sadism may be reluctant to seek or continue treatment for the fear of being reported to the police. Although the treatment is difficult because of the uncertainty of the causes, the outcome of this disorder is generally positive.
Next is masochism disorder.
The paraphilic disorder of sexual masochism. And their typical criteria for a person who suffers from this disorder, they must experience a reoccurring and intense sexual arousal from being beaten, humiliated, or bound. And they must experience this suffering for an amount of at least 6 months or more. And it has to cause significant trouble and distress in their lives. The typical features for someone who struggles from this is being sexually aroused from being inflicted with physical pain or humiliation. So, for examples of these are kind of like being bound, pierced, cut, spanked, whipped, handcuffed, and it can get even more intense as being actually like raped, or even further can be to be defecated on. Anything that can cause any type of arousal from being literally humiliated or things that are not socially norm for us, they tend to receive some type of pleasure out of. So these are the people that are on the receiving end of the pain, and it causes sexual arousal or sensation that they enjoy. So this is basically the opposite of a sadist, and those are the ones who inflict the pain. It can be self-inflicted but it is most commonly done with a partner. Its prevalence is truly unknown, and is due to the fact of many people are shame or believe there's a stigma behind going to the doctor and talking about their sexual preferences or their sexual feelings of that nature. But it is an estimation, according to DSM-5, that an estimated 2.2 males and 1.3 of females actually have a significant distress from this disorder. So they do actually, about that amount of people do have this disorder. But what causes, and what is the prognosis, and what is the causes of this disorder? Well, it's many theories. It's nothing set in stone, but they believe it can come from childhood trauma, so sexual abuse, or childhood experiences of seeing or being around sexual acts. Another example of that is a child watching pornography extremely early. It is also believed to be used as an escape method from any type of other distress going on into their life, to give them that feeling of being new or different. And also the last one would have to be basically someone who urges towards social deviance and violating norms. Someone who loves to push the boundaries of the norm tend to have those kind of features and causes of sexual masochism disorder. The diagnosis, basically it would be urges, fantasy, and behavior that must be present or prevalent for at least 6 months or more. It causes distress, and the distress can be as severe as severe guilt, shame, anxiety, obsessive thoughts, and causing an extreme interference between their personal and social life. Most people cannot handle a normal life because they're dealing with this disorder and don't seek treatment. Treatment and implications that can actually help. We tend to do psychotherapy treatment to uncover the underlying distress. Also, they try to use medication, SSRIs, antidepressants to help reduce sex drive. And also aversion therapy and imagery desensitization techniques. And this is to reduce sexual urges. So basically what this does is it shows you the negative qualities and the negative impact that this can have in a person's life by actually exposing them to the negative consequences. So basically you can also show people who deal with this disorder that it can be as worse as accidental death, which it has happened. It's very rare, but it has been accidental death due to someone practicing sexual masochism. Basically that goes into details about the opposite of sexual sadist is sexual masochism disorder.
Now on to fetishistic disorder.
Fetishistic disorder is a condition where the individual uses persistent and repetitive use of non-living objects, for example, like a high-heel shoe or an undergarment. They also focus on a certain body part, for example, like the feet or breasts, to reach sexual arousal. The symptoms for this disorder has to be at least 6 months reoccurring and is intense sexual arousal from either the non-living object or a certain non-genital body part. Diagnosis: the fantasies, sexual urges, or behaviors causes clinical significant distress or impairment in social, occupational, or other areas of functioning. Certain features there are fetish objects include female undergarments, male or female footwear, rubber articles, leather clothing, or other clothing apparel. Body parts are with this disorder include feet, toes, and hair. It's uncommon for sexualized fetishes to include both an object and a body part. For example, dirty socks and feet. This also includes holding, tasting, rubbing, inserting, or smelling the fetish while masturbating or preferring that a sexual partner utilize that certain object during sexual encounters. Causes for this disorder usually start in childhood, where children engage in sexual behaviors like masturbation or watching porn, and this develops as they get older. Common types of this disorder includes breast fetish, feet fetish, or shoe fetish. Breast fetish focuses on any type of breast. It could be women or men breasts, and it causes sexual arousal. For feet fetish, it could be a certain focus on a person's feet that causes sexual arousal. For shoe fetish, it could be a certain focus on a person's shoe, typically like a high heel shoe that women wear, that causes sexual arousal. Prevalence / prognosis. Prevalence is currently unknown since this disorder is rare and many individuals do not seek treatment. Prognosis is: this disorder is most common in people with schizophrenia, depression, anxiety, or even personality disorders. This disorder is most common in males, least common in females. The diagnosis ratio is 20-1, and that pertains to male to female. Treatments that are most effective for this disorder are cognitive and behavior therapy and medications. Treatment is normally long-term. For cognitive and behavior therapy is used to help the individual know the causes of their behavior and to teach them the skills to help them refrain from the inappropriate sexual desires. With medication, it helps them to target that compulsive thinking about sexual desires. Medication types are antidepressants, anti-anxieties, and SSRIs. Together, cognitive and behavior therapy and medications are the most effective treatments for fetishistic disorders.
And we will conclude with transvestic fetishistic disorder.
Transvestic fetishism disorder has many criterion in the DSM-5. They include 6 or more months of recurrent sexual arousal from cross-dressing. It's only a disorder if the behavior is distressing or causes discomfort in the individual. There is also a sub-disorder called autogynephilia, which involves being sexually aroused by thinking of yourself as female or having female functions or physiology. Men with autogynephilia are also at greater risk for gender dysphoria. Some of the features include wearing garments of varying amounts, wigs and makeup. Male teens with this disorder typically remove the clothes after masturbation, so it's not a permanent change. Distress could be financial or emotional, and autogynephilia focuses mainly on physiological functions, stereotypical feminine behavior, or feminine anatomy. The prevalence is generally unknown, as with most paraphilias, but it's rare in males at about 3% of males, but extremely rare in females. Many males with this disorder identify as heterosexual, but that might fluctuate whether or not they are actually in the process of cross-dressing. The prognosis and some of the causes are, you can see the signs of this disorder as early as childhood. It has a characteristic fascination with feminine clothes, and some of the comorbid disorders or symptoms are mainly other paraphilias, especially masochism and fetishism, and specifically with masochism, it's autoerotic asphyxia. Some of the diagnostic features are, it doesn't necessarily apply to all cross-dressing people, but applies to people who are sexually aroused by that certain act. Some of the cases of transvestic disorder transform into gender dysphoria, but the two are definitely distinct. People with gender dysphoria may seek medical interventions to feminize their anatomy, while transvestic fetishists won't. That's the distinction between transgender people and transvestic people. Some of the treatments and implications, some of the social implications include the conflation of transvestic people and transgender people. But the treatment for people that evolve from transvestic to transgender is generally gender therapy, which also includes hormone and surgical procedures, depending on how the person feels. And in terms of psychotherapy for transvestic people, it's more focused on psychotherapy to understand the internal distresses that result in this disorder.